Imagine you go in for a routine chest scan.
Right, just a standard procedure.
Yeah, exactly. Maybe you're checking on a persistent cough that just won't clear up, or maybe it's for something completely unrelated, like a minor rib injury from playing a little too aggressively in a weekend basketball league.
Happens all the time.
It does. So the scan is done, you're sitting in the exam room, scrolling on your phone to pass the time, and the doctor comes in, they sit down, they look at your chart, and they tell you they found a spot on your lung.
And instantly your stomach just drops.
Oh, complete panic sets in. I mean, for decades, that single phrase has felt like this terrifying, life-altering verdict.
Absolutely.
But what if I told you that this so-called spot is actually incredibly common? Like, what if it's something that appears constantly on scans, even if you have never touched a cigarette in your entire life?
It's a scenario that plays out in clinics around the world every single day now. And the frequency of it is increasing rapidly. We're finding more and more of these spots. But the reasons why we're finding them and what they actually mean for your long-term health are shifting drastically away from what we traditionally believed.
And that is the exact mission for today's deep dive. We're exploring a really fascinating paper published in the journal Radiology, authored by Dr. Suzanne C. Byrne and Dr. Mizuki Nishino. They're both from Harvard Medical School and Mass General Brigham.
Excellent sources.
Yeah, the data is incredible. We're going to figure out the new reality of lung nodules. We're looking at why all our old, deeply ingrained assumptions about smoking are they're being flipped completely upside down by this recent data. And we'll explore how artificial intelligence is stepping in right now to solve a massive, high-stakes medical puzzle.
To really understand the scope of this, we first have to look at the context of modern medical technology.
Right.
As medical imaging improves year after year, we are detecting things inside the human body that we simply could not see before.
It's just too detailed now.
Exactly. This creates a really fascinating tension in modern medicine. Because we have more data than ever, which sounds like an absolute win, right?
They think so.
But figuring out exactly what that data means for the individual patient, like differentiating between a harmless shadow and a real developing threat, that is the actual challenge we're facing today.
Okay, let's unpack this, starting with exactly what we mean when we use the term spot on the lung. In the medical world, this is called a pulmonary nodule.
Right.
And the clinical definition of a pulmonary nodule, based on the paper, is a circumscribed, typically round opacity that measures up to 30 millimeters in average diameter.
Which is relatively small, but
the most important thing to know right off the bat, just to ease some of that hypothetical exam room panic for you, is that the vast majority of these pulmonary nodules are completely benign. They are not cancer.
That's a crucial point.
Yeah, especially for the ones smaller than 10 millimeters. But of course, a small fraction of them are malignant.
And 10 millimeters is quite small, so you can imagine the sheer difficulty of looking at a scan and confidently declaring whether that tiny, isolated, round shape is just a harmless little bit of scar tissue from an old infection, or the very early stages of a malignant tumor.
It's got to be an immense burden on the radiologist reading the scan.
It is. It really is.
And to give you an idea of why this is happening so much more frequently now, I like to think of it like an analogy. It's like upgrading from an old 2005 flip phone camera to a modern 4K smartphone.
Oh, that's a great way to put it.
Suddenly you see every single speck of dust in the room. Right. Because we've transitioned so heavily to thin-section CT imaging and automated nodule detection software, our visual threshold has just completely changed.
We aren't just seeing the obvious larger masses anymore.
Right, we're picking up microscopic visual noise. The incidental detection rate has skyrocketed. In fact, research shows that when people get chest CTs for literally any reason, incidental nodule rates are commonly sitting between 25 and 40%.
Which means up to 4 out of every 10 people getting a scan have one of these nodules.
It's staggering.
And this brings us to a massive clinical dilemma. Early diagnosis of lung cancer is absolutely critical for survival. The earlier you catch it, the drastically better the patient outcomes.
Yeah, time is everything.
Radiologists are right there on the front lines of this battle. But looking at that high-definition scan and precisely differentiating a benign nodule from a malignant one it's incredibly fraught.
Because if they get it wrong in either direction.
Exactly. If doctors overreact to every single tiny nodule they spot, they subject patients to intense, unnecessary anxiety, highly invasive biopsy procedures, and just this constant cycle of follow-up scans.
They underreact.
They might miss a developing cancer while it is still highly treatable.
Traditionally, doctors used a very specific primary metric to guess whether that spot was dangerous. Smoking history.
The old reliable.
Right, it was the ultimate filter.
Yeah.
If you smoked heavily and had a nodule, alarm bells went off. If you didn't, the nodule was generally viewed with much less concern.
That was the standard protocol for a long time.
But there is a massive piece of research highlighted in our sources today that completely blows that old assumption out of the water. It's called the SCAPIS study.
Yes, the Swedish Cardiopulmonary Bioimage Study.
Published by Sørensen, Johnson, and their colleagues. This was a cross-sectional, population-based study across 6 hospitals in Sweden, looking at nearly 30,000 middle-aged participants.
A huge sample size.
Huge. And a quick, vital note on the location, they specifically did this in a population with a notoriously low incidence of fungal infections.
Which is very important to highlight.
Right, because certain fungal infections, like histoplasmosis here in the U.S., can leave benign scars on the lungs that look exactly like nodules. By doing this in Sweden, they largely removed that confounding variable.
What's fascinating here is the sheer volume of nodules they found in this generally healthy, middle-aged population.
Yeah, the numbers are wild.
Out of those nearly 30,000 participants, 33.9% had a solid pulmonary nodule of some size.
That is more than a third of the entire group walking around with a spot on their lung.
Exactly.
Now, you would assume, based on everything the medical community has taught us for decades, that the smokers in that group would have way, way more of these spots than the non-smokers, right?
That's the logical assumption based on the old rules.
So how much of a difference did the SCAPIS study actually find when they broke down the demographics?
The breakdown is where the real paradigm shift happens. For participants who currently smoke, the prevalence of nodules was 37.9%.
Okay.
For people who formerly smoked, it was 34.5%. And for participants who had never smoked in their entire lives,
Yeah.
the prevalence was 32.5%.
Here's where it gets really interesting. Those numbers are practically stacked right on top of each other.
They really are.
The difference between someone who has never touched a cigarette and someone who currently smokes is just a few percentage points when it comes to the mere presence of a nodule.
Exactly. A 32.5% rate in never smokers versus a 37.9% rate in current smokers. This completely challenges the traditional medical reliance on smoking history to stratify a patient's baseline risk.
It has to.
If a third of people who have never smoked have these nodules, then simply asking a patient, "Do you smoke?" cannot be the primary filter we use to decide who is at risk and who isn't.
Right.
Furthermore, the SCAPIS study found something else incredibly important regarding the participants who had never smoked. If they had nodules that were 100 cubic millimeters or larger, those nodules were strongly associated with other underlying non-smoking-related lung issues.
What kind of issues are we talking about?
Things like reticulation, which is a kind of network-like scarring in the lung tissue, or bronchiectasis, which is a condition where the airways become permanently damaged, widened, and thickened.
Wow.
They also found associations with other lung diseases entirely outside of the standard asthma or COPD diagnoses you might expect.
So the nodules in those never smokers aren't just random, meaningless shadows or artifacts on the scan.
No, not at all.
They are actively signaling that something pathological is happening in the lungs, even if it has absolutely nothing to do with tobacco smoke.
Precisely.
Which perfectly sets up the next major issue. Dr. Brun and Dr. Nishino bring up lung cancer in never smokers. The text explicitly calls this an emerging public health concern.
It really is becoming a major focus.
For a long time, getting lung cancer when you had never smoked was viewed as this rare anomaly, almost a statistical fluke. But now it's becoming a highly recognizable global mystery that researchers are scrambling to decode.
And to understand that global mystery, we have to look at a separate piece of major research called the TALENT trial.
The Taiwan lung cancer screening in never smoker trial.
Yes. This was a multi-center prospective cohort study in Taiwan. And unlike older trials that focused on heavy smokers, this one zeroed in entirely on the exact demographic we are talking about, never smokers.
Okay.
What the researchers found is that when you remove smoking from the equation entirely, a whole new set of distinct risk factors emerges.
What were they?
For never smokers, the risks for lung cancer were heavily associated with being female, having a family history of lung cancer, and being over the age of 60.
So, In Taiwan, they are identifying this very specific profile, older women with a family history of the disease who are at heightened risk despite having zero smoking history.
Exactly.
But how does that data from an East Asian cohort connect back to the study we just talked about in Sweden? Are these just isolated regional issues?
If we connect this to the bigger picture, comparing this East Asian data from the TALENT trial with the Northern European data from the SCAPIS study provides incredibly valuable global insight.
How so?
Well, for quite a while, the issue of lung cancer in never smokers have been explicitly noted and heavily studied in East Asia. Because of that, there was a lingering question in the global medical community of whether this was just a localized phenomenon, perhaps tied to specific regional environmental factors.
Like local air quality or something.
Exactly. But the SCAPIS study proves this isn't just an East Asian concern, it is happening in Northern Europe, too.
So it's everywhere.
Yes. As the authors of the paper point out, we need to aggressively decode the differences and similarities of this disease across different parts of the globe. The pathology is highly complex, and the old universal rules of thumb just do not apply anymore.
So what does this all mean? If you are a patient right now, today, sitting in that exam room with a freshly discovered nodule, how do doctors actually try to guess if it's dangerous, given that they can't just rely on whether or not you smoke?
Currently, the standard of care relies on what are called validated risk prediction models. You might hear names thrown around like the Mayo Clinic model, the Brock model, or the Veterans Affairs model.
And what are those, essentially?
They're basically complex statistical formulas. The radiologist or the referring doctor inputs a variety of variables about you into the model. They look at your age, the exact size of the nodule, your smoking history, your family history of lung cancer, and specific radiographic features of the nodule itself.
What kind of physical features are they looking for on the scan?
They look at the location of the nodule in the lung, its density, whether it is solid or what they call ground glass, which looks a bit hazy, and importantly, whether it has spiculation.
Speculation.
Yeah, spiculation means the nodule has spiky, uneven, star-like edges. That can often be a hallmark of a growing invasive tumor, as opposed to a smooth, perfectly round, benign cyst.
Okay, it sounds like a pretty thorough mathematical checklist. But Dr. Byrne and Dr. Nishino point out that this old guard of risk prediction has some pretty major inherent flaws when you try to apply it to the modern landscape of patients.
Well, think about who those models were originally built for.
Right.
The first major limitation is that these predictive models are usually best applied only to the specific demographic populations they were developed in.
That makes sense.
If you take a formula based heavily on data from older male veterans who smoked for 40 years,
Right.
which is the case for some older data sets, and you try to apply that exact math to a 62-year-old woman in Taiwan who has never touched a cigarette, the prediction simply falls apart.
The underlying baseline risks are just completely different.
Precisely. Secondly, as we just established with the SCAPIS data, these older models still heavily over-rely on smoking history and the sheer physical size of the nodule as the key drivers of cancer risk.
Which we now know misses a massive portion of the picture.
Exactly. And perhaps the most practical day-to-day flaw is that these models require a vast amount of detailed patient history to work accurately.
Oh, and the radiologist might not have that.
Right. Often, a radiologist is sitting in a dark reading room analyzing a CT scan for a patient they have never met. They might not have immediate access to that patient's detailed family history or their precise smoking habits at the exact moment they have to make a definitive call on that scan.
Which leaves the radiologist flying a bit blind, relying almost entirely on the visual of the scan itself and their own past experience.
It's a tough spot to be in.
And that is exactly where the technological twist comes into our deep dive. Enter the AI revolution. Artificial intelligence and a specific field called radiomics are stepping up to completely change how we analyze these scans.
It's a game changer.
Before we get into the results, how exactly does radiomics differ from a human doctor looking at an image?
Radiomics is a fascinating field. When a human looks at a scan, they see shapes, borders, and general shading. Radiomics treats the medical image not as a picture, but as a massive data set.
Like looking at the matrix.
Basically, AI algorithms extract thousands of quantitative features from the image, things like microscopic texture patterns, pixel-level density variations, and spatial relationships that the human eye literally cannot perceive. It turns the visual of the nodule into complex mathematics.
And researchers are finally testing how well that mathematical approach works against traditional human methods. The paper highlights a specific study by Choi and colleagues where they developed a new radiomics model to predict nodule malignancy.
And they pitted it directly against the traditional system used by the American College of Radiology.
Right, which is called Lung-RADS. Lung-RADS is essentially a rigid categorization system doctors use to manage these findings, and the results of the study weren't even close.
The AI significantly outperformed the traditional Lung-RADS method. The AI Radiomics model achieved an accuracy of 84.6% in predicting malignancy.
Wow.
That is a full 12.4% higher than the Lung-RADS system.
That's a massive jump.
It is. In statistical terms, researchers measure this kind of diagnostic performance using a metric called the area under the curve, or AUC.
Okay.
An AC of 1.0 means perfect prediction every single time, and an AUC of 2.5 is essentially a coin toss.
Got it.
The traditional Lung-RADS model had an AUC of 0.77. The AI Radiomics model jumped up to an AUC of 0.89. In the world of medical diagnostics, that is the highly significant leap in confidence.
And it isn't just a single isolated victory in one lab. The paper layers in multiple studies showing these real-world tech victories. There was a large multi-center study by Mashin and colleagues that looked at nodules human doctors had classified as indeterminate.
Which is a very common classification, unfortunately.
That basically means the doctors looked at the scan and said, we just aren't sure. It's too ambiguous. We have to wait and see.
Right.
But when they ran those same indeterminate nodules through an AI algorithm, the AI successfully and correctly reclassified them as either benign or malignant.
That's huge. Imagine the immense psychological relief for a patient finding out immediately that their ambiguous nodule is actually benign, instead of spending 6 agonizing months waiting for a follow-up scan, wondering if cancer is growing inside them.
The reduction of that psychological toll alone is a huge clinical benefit.
Absolutely.
And another major study by Antonison and colleagues proves how adaptable this AI can be. They took a deep learning algorithm that was originally trained on data from the National Lung Screening Trial here in the U.S., and they applied it across multiple European screening data sets.
Testing if it works across different demographics.
Exactly. And the AI systematically outperformed the traditional Brock model we discussed earlier. Not only did it predict malignancy better across a different population, but crucially, it heavily reduced false positive classifications.
A false positive is exactly what we want to avoid.
Because that causes so much unnecessary panic, right?
Absolutely. A false positive means telling a patient their scan looks like cancer when it actually isn't. That triggers the anxiety, the incredibly stressful consultations, and potentially highly invasive, painful biopsy procedures that carry their own physical risks.
Right.
The AI is simply proving to be vastly better at filtering out the anatomical noise and identifying the true threats.
Hearing all this, the massive leaps in accuracy, the reduction in false positives, the ability to decode indeterminate nodules, I have to play the skeptic on behalf of everyone listening.
Okay, go for it.
If AI is this incredibly accurate, if it is handily beating out the old clinical formulas and saving patients from unnecessary biopsies, why isn't every single hospital in the world using it immediately? Why isn't this standard practice everywhere as of today?
This raises an important question, and it touches on one of the biggest philosophical and practical hurdles in modern medicine today.
Yeah.
It is the concept of the black box.
The black box.
Yes. In the highly regulated, high-stakes field of radiology, there is a distinct hesitancy and deep skepticism surrounding the rapid adoption of AI because doctors cannot fully understand the inner workings of how the algorithm actually reaches its conclusions.
Right, because when a human radiologist says a nodule is concerning, they can point directly to the scan and explain their reasoning to the patient.
Exactly.
They can say, look at this spiky speculation on the edge here, and the density in the center is worrying. They show their work.
Precisely. But when a deep learning AI says a nodule is malignant, it is basing that entirely on millions of calculations involving those microscopic pixel-level patterns we talked about with radiomics.
It can't explain itself.
It gives an incredibly accurate answer, but it cannot verbally explain its work to the physician. The doctor knows the mathematical output suggests cancer, but they don't know the why.
Yeah.
And in medicine, when a patient's life is on the line and malpractice liabilities loom large, doctors are understandably terrified of blindly trusting a machine they don't completely understand.
But Dr. Byrne and Dr. Nishino offer a very clear path forward in their paper, and the solution isn't about setting up a battle of man versus machine, it is all about synergy.
It has to be.
They point to a study by you and colleagues that showed the ultimate diagnostic solution is human-AI collaboration. When expert human radiologists work in combination with the AI models, their overall overall performance in detecting lung cancer is greater than either the human working alone or the AI working alone.
That's the ideal scenario.
The machine acts as an incredibly powerful, tireless assistant, flagging the invisible radiomic patterns, while the human doctor applies their crucial medical context, their years of clinical judgment, and their holistic understanding of the patient sitting in front of them.
It is the ultimate team-up, marrying computational power with human intuition. But to get past that black box apprehension and make this team-up a standard reality, the medical field has some significant work to do.
What needs to happen first?
As the authors point out, we need a deepening transparency about how these algorithms actually function. The software developers need to innovate ways to make the AI explain itself better to the doctors, perhaps by highlighting the specific visual areas of the scan that heavily influenced its calculation.
Like giving the doctors a map of the math.
Exactly. And alongside that push for transparency, we desperately need more real-world demonstrations of their utility in clinical settings.
Proof of concept in the real world.
The more doctors see the AI correctly identifying tricky, ambiguous cases in their daily practice without causing harm, the more that inherent skepticism will fade into trust.
And to make these AI models even smarter and more personalized, they need a constant diet of high-quality data. Which brings us all the way back to the SCAPIS study we discussed earlier.
The Swedish study.
Right, that massive study of nearly 30,000 middle-aged Swedes. It didn't just end after they counted up all the nodules.
No, it didn't. They are currently collecting long-term malignancy outcome data on all of those participants.
That's going to be a goldmine of information.
In the future, when that massive data set is finally reported, we will know exactly which of those thousands of seemingly benign nodules eventually turned into cancer and which ones remained harmless for decades.
Wow.
That kind of massive, long-term population-based data is the exact key required to feed these algorithms and create truly personalized risk modeling. We are moving away from broad generalizations and toward highly specific, individualized care.
It is genuinely incredible to think about where this field is heading in just the next few years. So, to wrap up our deep dive into this radiology paper today, let's do a quick recap of the biggest takeaways.
Good idea.
If you remember nothing else from this discussion, remember these three key concepts. First, finding a lung nodule on a scan is incredibly common, affecting roughly a third of all middle-aged people. So hearing the doctors say they found a spot is no longer an immediate reason to panic.
Spot on.
Second, your smoking history is no longer the sole definitive predictor of your lung cancer risk. Never smokers develop these nodules too, and they carry their own unique, complex set of risks that the medical world is urgently working to decode on a global scale.
Absolutely crucial to remember.
And third, the future of healthcare isn't going to be human doctors replaced by cold, calculating robots. It is going to rely on humans teaming up with artificial intelligence to see the microscopic threats we simply cannot perceive on our own.
The shift toward a truly personalized approach to managing pulmonary nodules is no longer just a hypothetical concept discussed in academic journals. Between the massive global studies redefining baseline risk and the advanced radiomics models vastly outperforming traditional scoring methods, this personalized approach is exactly what the authors call it, the wave of the future.
It's happening right now.
The technological tools are evolving at breakneck speed, and the way we fundamentally understand the disease is evolving right alongside them.
Which leaves us with one final provocative thought for you to mull over. We spent some time talking about the AI black box dilemma that deep apprehension doctors feel because they cannot see exactly how the AI makes its life or death decisions.
Right.
But think about this from your perspective as the patient. If an AI analyzes your medical scan and spots a microscopic, pixel-level radiomic pattern that ends up catching a tumor early and saving your life, and it does this even if no human mind on Earth can fully comprehend exactly how the AI saw it, how much does the how really matter to you?
That is the big question.
As we step further into this brave new world of highly personalized, AI-driven medicine, where exactly should we draw the line between needing to fully understand our tools and simply trusting them to save us? It is a complex question that doctors, software developers, and patients are all going to have to answer together in the very near future. Thank you for joining us as we explored these sources today, and we will catch you on the next deep dive.